Okay, last time we stopped at the corneal disorders, so we are continuing our journey with the pediatric ophthalmology. So, as I told you the last time, assume that you are sitting in a pediatric ophthalmology clinic, and what are the types or kinds of cases that you are expecting to see in this clinic? Mostly that you will find cases that spanning all specialties in ophthalmology. So this is what we are going to discuss here. We are covering the most common pediatric ophthalmology problems in each subspecialty. Okay. Okay. So let's start with the corneal disorders. So what kinds of corneal lesions that you may expect in a pediatric ophthalmology encounter? So you may expect that you will have some patients with congenital disorders. So what are these congenital disorders? And first, what is the difference between congenital and developmental? So a developmental is a lesion which may be present at birth, and these lesions are due to alterations or changes to normal growth and differentiations, and they can present later on in life. So they can be present in the first few months in life and or can be present later on in life, but they are due to problems with the normal growth and the maturation and differentiations of the different body organs. However, the congenital is a disease which is usually present or it's always present at time of birth. So if there is a lesion present at time of birth and there is no etiological process in it, like there is no genetical abnormalities, or there is no process of injury. So this is what we call congenital. For most of the corneal lesions, it will be a problem during the maturation and differentiation and the growth of the corneal tissues, and usually they are caused by underlying genetical disorders. So they are mainly a developmental anomaly. So to classify these corneal anomalies or these developmental corneal anomalies, this can be either an absence of cornea, a total absence of the cornea, or there is abnormalities in the corneal size or abnormalities in the corneal shape. So how does a cornea absence should look like? It could be a true absence of the cornea. So there is no cornea formation at all. There is agenesis of the cornea, or there is a true cryptophthalmos. The cornea is there, but it is just concealed by the eyelids, or pseudocryptophthalmos. I'm going to show you what is this right now. Or it could be anomalies of the size, like the cornea could be large or megalocornea, or could be small, like a microcornea. There could be anomalies of the shape, like there is sclerization or scleronization of the cornea, like sclerocornea, or now it is the cornea plana, or a flat cornea can be also referred, both of them can be referring to the same entity, or a posterior keratoconus, could be either generalized or circumscribed, or keratoglobus. So let's start with every one of those anomalies and see what are the hereditary pattern and what are the clinical features, starting first by the absence of the cornea. So if we have if a patient have a true absence of the cornea, how does this look like? Well, first of all, it is very rare and it is never an isolated anomaly. So if a patient has true absence of the cornea, this will be mostly always present with agenesis of other different anterior segment structures. So like for example, they could be associated with congenital aphakia or abnormalities of the other anterior segment structures, like including the iris, the sometimes even in ophthalmos, it can be present with total absence of the eye. So this is like the extreme example. So we are just taking like a part of the anterior segment or a part of the eye which is not present. It is called the true absence of the cornea. With the absence of the cornea, so starting by the true cryptophthalmos, it is called the Fraser syndrome. In the Fraser syndromes, the eyelids fails to separate. So you can see that there is uninterrupted skin continuity from the forehead to the eye to the molar bone. The skin is continuous. the eyelids failed to separate the risk fusion of both eyelids. However, in the true cryptophthalmos, you cannot see a true eyelid or eyebrow. They are continuous. There is fusion of the skin. So the good news about this disease is that the conjunctiva and the cornea underlying this skin is normal. So that's why those patients will be having a better prognosis to have a surgical opening to allow visual sight through this opening. So we are like trying to create a palpebral fissure for them to allow light to enter through these eyes. And the true cryptophthalmos, or what's called Fraser syndrome, is associated with other craniofacial anomalies, like, as I told you, spina bifida or cleft lip or cleft palate. So this is the condition of true cryptophthalmos. On the other hand, patients with pseudocryptophthalmos, this is usually an autosomal recessive disorder and bilateral condition. So again, the absent eyelashes. The lashes and the eyebrows are present. You can see here. So ignore this. Ignore absent eyelashes. The eyelashes and the eyebrows are present, but they are, you see, they are stuck together. There is failure of separation of the eyelids, but they are already present. That's why it's called pseudo cryptophthalmos. Sometimes it is mentioned or it is referred as total ankyloblepharon. There is total adhesion of both eyelids. So the cornea also is present and the eye is otherwise normal, and also the craniofacial anomalies are common. Those patients usually, oh, so when I'm trying to prepare some slides, they are, okay. So craniofacial anomalies, this is not correct, and this is not correct. So again, what we are saying that it is autosomal recessive disorder, bilateral disease with lashes and brows are already present, and the eyes looks normal, and also craniofacial anomalies are common. So the treatment again is to do surgical cleavage or separation between both eyelids. Okay, so these are the absence of the cornea or the congenital anomalies related to the absence of the cornea. When you see a child who is born without a cornea, you suspect whether there is total absence of the cornea, or there is total absence of the eye or enophthalmos, or the eye is present, but it is just the eyelids are covering it. It could be true cryptophthalmos where the eyelids didn't form, or pseudocryptophthalmos where the eyelids are formed, but they are just didn't separate. You can see these bands of adhesion, these of ankyloblepharon. Okay. Now let's move to talk about the anomalies of the size. And in order to know what are the anomalies of the corneal size, we need to know what is the normal corneal size. The normal horizontal diameter of the newborn cornea is around 10 millimeter. This horizontal diameter increases until it reaches the adult corneal size, which is 12 millimeter, by the age of 2 years usually. So the adult corneal size is 12 millimeter, while the neonatal corneal size is 10 millimeter. Most of cases, we refer to the horizontal diameter, which is the most accurate, because if there is a vertical diameter, can be sometimes concealed by the presence of pannus or any lesion. So the horizontal diameter will be more relevant to the actual corneal size. So, and usually the horizontal diameter is more than the vertical diameter by 1 millimeter. Okay, so these are the normal measurements. So what will be the abnormal measurements? First of all, the megalocornea or a large cornea. So when do we judge a cornea as a large cornea? This is when the corneal diameter, the horizontal diameter, is equal or more than 13 millimeters. So you can see this cornea is 14 millimeters. In this case, it is called a large cornea or a megalocornea. This disease is bilateral and symmetrical, and it is X-linked disorder. For those who are attending ICO exams, this is very important and asked before in the clinical ICO exams before. The megalocornea is X-linked, meaning that it is more in males. So I even brought to you the mutation of the gene. It is mutation in the gene of CHRDL1, which is present on X chromosome. X chromosome on the long arm of the X chromosome and Lucas 23. So remember that megalocornea is an X-linked disease. So does it mean that it's always X-linked? Again, focus for the MCQs. No, doesn't always have to be an X-linked. It can be present also as autosomal dominant or autosomal recessive or even sporadic. But the most common is to be an X-linked. And actually, the etiology of the megalocornea is unknown, but there are many theories that just a defect in the growth of the optic cup, where the anterior tips of the cup fails to close. So this means that there is larger space to be taken by the cornea. So this will be one theory. An important differential diagnosis when you see a neonate or an infant with large cornea is you must think of congenital glaucoma. And we will talk about how to differentiate. But generally speaking, we know that in those patients with megalocornea, they have large cornea, but they don't have any other features of congenital glaucoma like elevated intraocular pressure or habestria or optic disc changes. The cornea looks clear. And also there will be sharply demarcated limbus. And you know, in the congenital glaucoma, there is disorganized limbus or stretched limbus. It is a distorted anatomy of the limbus in congenital glaucoma, which is not the case with patients of megalocornea. Okay, so this is for patients with megalocornea. And let's now talk about the other condition. You see, this is the congenital glaucoma. This is will be one of the major differential diagnoses. For microcornea, on the other hand, the horizontal corneal diameter is equal or less than 10 millimeters in otherwise normal sized globe. This is very important to differentiate the microcornea from microphthalmos. So microcornea is a small cornea in a normal sized globe, while microphthalmos is total or all structures of the eye are small. Okay, so you can see this is a patient with microcornea, and the horizontal corneal diameter is around 9 millimeter. This patient is wearing a rigid gas premium contact lens. If you are wondering what is this, because it appears that he has aphakia behind. And this condition can be unilateral or bilateral, can be autosomal dominant or recessive with few sporadic cases. The differential diagnosis of this patient is, first of all, the anterior microphthalmos. And what is meant by anterior microphthalmos? That it is not only the cornea is small, but the whole anterior segment, like a small cornea, small iris, small lens, the entire anterior segment is small. Also should be differentiated from microphthalmos, where the whole eye is small and disorganized, or nanophthalmos, where in nanophthalmos the whole eye is small but it is normal. So don't forget, anterior microphthalmos, the anterior segment is small. Microphthalmos, the whole eye is small but disorganized. Nanophthalmos, the whole eye is small but it is normal. Okay, so this is the differential diagnosis of a microcornea. Let's now talk about the anomalies of the shape. What are the anomalies of the shape that the cornea could show? There is a disease called sclerocornea or cornea plana. So are they two different diseases? Well, let's see. The cornea in the sclerocornea or cornea plana, the cornea is flat. So we know that the corneal curvature is between like 43 to 44 diameter or diopters. So if you find that the cornea is flat with the curvature is less than that, like between 20 diopter to 35 diopters, you can see how much is the cornea is flat. And in this case, we call it like a cornea plana. And in cornea plana, there will be always that the corneal curvature is equal or less than the scleral curvature. So you can see that the sclera is curved. However, the cornea is flatter. And this sign is almost always present, like it is pathognomonic sign for the presence of cornea plana or sclerocornea. So why do we say that both of them are the same disease? Because it was found that all patients with cornea plana, they have the sclera is migrating toward the cornea, or there is scleralization of the cornea. Could be either peripheral or central like that. So you can see that this is a sclerization of the cornea, and the cornea also looks flat. So both of them happens in the same case. And it was also found that they have similarities in systemic associations, they have similarities in ocular associations, they even have similarities in the histopathological pattern or inheritance pattern. So they are now referred to the same condition. Most of cases or of those patients are bilateral and asymmetrical. So it is commonly to be asymmetrical rather than symmetrical. And most of cases are sporadic. However, the autosomal recessive become more severe. So for patients with maybe sporadic, you can find that the sclerization is peripheral. However, for patients who have autosomal recessive, it is more commonly to be more central or total sclerization of the cornea. And of course, the treatment for those cases will be penetrating keratoplasty in case of central corneal opacification. However, with guarded prognosis due to many complications, most importantly, the glaucoma. So this is one of the anomalies of the shape of the cornea or the sclerocornea. Another anomaly, which is called the posterior keratoconus. In the posterior keratoconus, it is different from the anterior keratoconus, as the anterior keratoconus occurs in the first 20 years of life. However, so we cannot consider it like a developmental disorder. While the posterior keratoconus start very, very early in life, it is usually unilateral and non-progressive, non-inflammatory, and associated with normal visual acuity. So concentrate for the MCQs. If he says that the posterior keratoconus has impaired visual acuity, no, usually they have normal visual acuity. Regarding the distribution of the posterior keratoconus or the lesion, it can be either circumscribed like that, involving only a small area of the posterior corneal surface, or it can involve the entire posterior corneal surface. In this case, it will be called generalized posterior keratoconus. And for those who don't know, in keratoconus, there is increasing the curvature, or by keratoconus, we mean that there is increasing the normal corneal curvature. So you can see that the posterior cornea is more curved than the rest of the posterior surface. And the same also happens with the anterior cornea or the regular keratoconus. There is increasing in the curvature. Okay, so the posterior keratoconus, it will be either limited or what's called circumscribed form. There will be increasing in the curvature in a limited part of the posterior surface, or it will be generalized involving the entire posterior surface. Again, I can't stress enough on that the cornea is almost always clear. So unlike the keratoconus, you will not find like the Vogt stria and the apical scarring and the stromal opacities that may happen in the normal or the anterior keratoconus. This is not the case here. Most of cases are sporadic, and all the cases that were discovered for posterior keratoconus are females. So this is also important to note. So this is one of the anomalies of the shape, which is the posterior keratoconus. Another lesion, which is which is considered as anomaly of the shape, is the keratoglobus. So we know that the cornea is thin in the center and thicker in the periphery, and it will be more curved in the center and more flatter in the periphery. So this normal distribution or normal arrangement will be different in keratoglobus. In keratoglobus, it is a bilateral non-inflammatory ectatic disorder in which the entire cornea becomes thin and takes a globular shape. So instead of the prolate shape that the normal cornea should assume, which is like flatter in the periphery, more curved in the center and flatter in the periphery, the cornea become globular. And instead of having a thin cornea in the center and thicker cornea in periphery, the whole cornea will become thin. So this will be, the cornea will be uniformly thin from limbus to limbus. The cornea, as it is an ectatic disorder, so there is ectasia, this means that there will be higher curvature. The cornea will be more curved, like you can see here. Let me just clear this. Okay, so you can see that the cornea is highly curved, meaning that the K readings will not be 45 or 44, it will be like 60 to 70 diopters. The cornea is clear, normal in size in terms of the horizontal corneal diameter, and diffusely thinned to 1/3 to 1/5 of the normal corneal thickness. And regarding this curvature, there will be, as you can see, very deep anterior chamber. However, otherwise, the anterior segment is normal. There is normal iris, normal lens, normal anterior segment, and normal globe. Okay, so does this mean that the cornea is always clear? No, due to that the stretch of the cornea, because in ectatic disorder, it can result in a stretch of the descent, which can result in tear in the descent causing hydrops. So those cornea can be edematous at some times if there is break in the descent membrane. However, in most of occasions, they are clear. It was found that there is an important association of keratoglobus with an important collagen disorder, which is called the Ehlers-Danlos syndrome. In Ehlers-Danlos syndrome, there will be hyperflexibility of the joints. There will be also deafness. So for those patients, they have fragile eye. Their eyes may have a tendency to rupture easily, or they can show rupture globe with the slightest stroma. So those patients should be managed with care, and they should be counseled about that. Surgical interference for those patients is problematic and usually can be done by two-stages approach with epikeratoplasty or tectonic lamellar corneoscleral graft first, then followed by penetrating keratoplasty some weeks or months later, but not the best outcome for those patients. Okay, so this is the anomalies of the corneal, developmental anomalies of the cornea. Is it clear? Any questions so far? So to summarize it again, we have anomalies of the cornea itself, like absence of the cornea, which can be true absence, or true cryptophthalmos or pseudocryptophthalmos. It can be anomalies of the size, as it can be microcornea or megalocornea. It could be anomalies of the shape, like it could be cornea plana or sclerocornea. Both of them refer to the same term, or keratoglobus, or the posterior keratoconus. Okay. The next most important topic about the pediatric corneal problems is the congenital corneal opacity, or what's referred to as opacification of the cornea at birth. In order to remember it, there is a famous mnemonic which will contain the most causes of corneal opacity at birth, which is called STUMP. So each letter of this mnemonic will refer to a certain disease or certain group of diseases. So what will be this mnemonic referred to? S refers to sclerocornea. T refers to tears in the descent membrane. U refers to uterine infection or ulcers. M refers to metabolic or the metabolic disorders characterized by mucopolysaccharidosis or mucolipidosis. P or posterior defect like Peters anomaly. E for edema like congenital hereditary endothelial dystrophy or congenital hereditary stromal dystrophy. And finally, D for dermoids. So STOMPED refers to what are the differential diagnoses of a corneal opacity at birth. Sclerocornea, tears in the desmus membrane, ulcers or corneal ulcers or infection, metabolic, Peters anomaly, corneal edema, or dermoid. So let's start with the first one, which we already discussed, the sclerocornea. Sorry for that. Sclerocornea, as we just mentioned, it is a sclerization of the cornea. So you can see that the sclera is encroaching over the limbus and over the cornea, leaving either the center of the cornea is clear, or sometimes, so in this case, we call it a peripheral corneosclera or peripheral sclerocornea, or sometimes it can be involve the periphery and the center of the cornea, which will be more, which is the central, which, as I told you, more common with the autosomal recessive type. So this will be one of the differential diagnoses. So in order to diagnose that, you can do the UBM or ultrasonic biomicroscopy to see the lines of separation between the limbus and the cornea to know what are your boundaries and what is underlying this sclera. So this is the first letter of the word STOMPED, which is the S, sclerocornea. T refers to the tears in the desmus membrane. Tears in the desmus membrane can be mechanical due to forceps trauma. You know, in the past, there were, like in the obstructed labor or in difficult vaginal surgery, obstetricians use some tools in order to mechanically grasp the child head and bring it out of the birth canal. One of these tools, you use what's called the forceps. So it was thought that this forceps, when grasp the child's head, it will be over the lips of this forceps will be over his orbit, and this will cause like what you can see here, like, just hold on. So this is what I'm going to say, the vertical. So it will be like grasping over the orbit, and this will result in that there will be horizontal stretch of the cornea, leading to stretch of the corneal tissue with vertical splitting of the desmus membrane. So you can see it by the direct illumination or the retro illumination. You can see that there is vertical lines in the desmus membrane. And when you see this, you check for the patient. This is actually my patient. When I saw here, I saw some vertical lines on the desmus membrane. I suspected that this patient had a forceps delivery. So when I saw her in the general appearance, I found that the marks of the forceps delivery. You can see this dimple on the forehead. This is actually the site where the lips of the forceps are grasping her forehead to facilitate the delivery. So tears in the desmus membrane can lead to these horizontal or vertical lines. Sorry, it is vertical, can be vertical or oblique. And this will be one of important signs of tears in the desmus membrane. It will be the presence of vertical or oblique tears in the desmus. Also, so you may say, okay, but where is the corneal opacity here? Sometimes due to the stress of the desmits and the stress of the endothelium, those patients may decompensate later on in life, leading to corneal edema, and that will require penetrating keratoplasty. So they can present with acute edema, and this acute edema sometimes can absorb or can resolve depending on the ability of the endothelium to withstand this stress. And can also show these scars present in the desmus membrane. And the other differential diagnosis of the tears in the desmus membrane is the congenital glaucoma. Again, congenital glaucoma will cause a stretch of the ocular tissue under the effect of the intraocular pressure. And since that the children have elastic ocular tissues, they will stretch under the effect of intraocular pressure, leading to horizontal tears in the desmus membrane that is sometimes referred to as HAB stria. HAB stria are horizontal tears present in the desmus membrane, which can also lead to edema scarring. In order to remember them, remember that in the glaucoma, horizontal represent HAPS. HAPS for horizontal, H for H. And the vertical or oblique for the forceps delivery. The problem with these stria that they can cause astigmatism, marked astigmatism, even from 4 diopters to 9 diopters, and this can result in amblyopia if it was not recognized early in life. So it is very important for those patients that they may not have drop of vision from the Descemet's break, but they will have drop of vision from the astigmatism and amblyopia. So this is the second T, or the second differential of the corneal opacity at birth. The third differential for corneal opacity at birth is U, or corneal ulceration and infection. So it is not common, to be honest with you, since even from the 18th century that we just mentioned the last time, that obstetricians used the silver nitrates eye drops as a chemical prophylaxis against birth-acquired infection. So it is not very common. And even after the advent of erythromycin and antibiotics eye drops with perinatal prophylaxis, there will be more like even prevention of the corneal ulceration and the infection. So it is rare. However, it can occur, but it is still an important cause of congenital corneal opacity. When we suspect that suspect by the presence of an epithelial defect, like you can see here, this is a neonate with epithelial defect that takes the geographical atrophy, the geographical ulcer of the herpes simplex virus. So when you see an epithelial defect in neonates, this is very suspicious and examine for corneal ulceration. So what are the causes? For many cases, it will be viral. And in viral, it will be caused by herpes simplex type 2 more commonly, because the herpes simplex virus type 2 is the one that will cause infection below the waist, leading to transmission to the child from the mother. So it is in 80%, while the herpes simplex virus type 1, it will be only in 20%, causing infection because it is responsible for infections above the waist. And in those patients, you may find the characteristic features of vesicles present in the skin of the eyelids of those patients. Like there is a blepharoconjunctivitis associated with keratitis. This means that this child has a herpes virus infection. And for bacterial, sometimes it is not viral, it can be bacterial. And again, it is not commonly to be primary, but more commonly to be secondary to neonatal conjunctivitis, as we mentioned in the last lecture about the gonococcal conjunctivitis. So the gonococcal conjunctivitis can result in corneal ulceration and corneal perforation, okay, if not treated. And also there is another cause for corneal ulceration in neonates, which is the neurotrophic corneal ulcer. Neurotrophic corneal ulcer can cause secondary to what's called Rayleigh syndrome. In Rayleigh syndrome, the other name is familial dysautonomia. There is a condition associated with generalized dysfunction of the autonomic nervous system. So this will be like there is different manifestations, like motor incoordination, like there is increased sweating, and also that in those patients the corneal innervation is deficient. There is loss of the corneal innervation leading to neurotrophic keratitis. So these are the main three reasons for corneal ulcer that will result in corneal opacification at birth. Okay. Dr. Ramia, HAB stria for after birth and glaucoma, stria Vogt line is vertical or horizontal? No, like Vogt lines, they are vertical, while the HAB stria are horizontal. So I was going to say that in the cornea lecture, so how would we differentiate between the HAB stria and the Vogt lines or Vogt stress lines caused by keratoconus? So an easy way is to remember H for H and V for V. Horizontal for HABs, vertical for Vogt. Okay, and for the birth trauma, they are vertical or oblique. Why? As I told you, when we are when the forceps is grasping the point, when the forceps is grasping the child head. Why does this happen? Like me, bring me my pen. Okay, I don't know. For some reason, the pen is not working. Okay, when the forceps is holding the child's head, it will be has its lips like that and like that. Okay, so they will cause or sorry, it will be like not vertical. It will be horizontal. So when the forceps is grasping the child's head, it will be horizontally oriented, like it will be like that. So it may grasp the child head from the horizontal and pull. So this will lead to causing a vertical tear in the dismus membrane. Okay. It will cause a vertical tear or an oblique tear, but due to the orientation of the forceps, it will not be horizontal. Okay, so this is for the corneal ulceration and infection. What will be the next cause of the corneal opacity at birth? It will be the metabolic causes or the metabolic reasons for corneal opacification. It will be the mucopolysaccharidosis and the mucolipidosis. So what are the mucopolysaccharidosis and the mucolipidosis? Those are group of metabolic diseases characterized by enzymatic deficiency. So these enzymes are important for production or for metabolism of certain mucopolysaccharides and mucolipids. For mucopolysaccharidosis, they are sometimes referred to as lysosomal storage diseases. And what is asked in the MCQ exams that the all are autosomal recessive except the Hunter syndrome. Hunter syndrome is an X-linked recessive. Another group of diseases called the mucolipidosis, which are characterized by disorders in the lipid metabolism. They are also all autosomal recessive except the Fabry's disease, which is X-linked recessive. Again, all mucopolysaccharidosis are autosomal recessive except the Hunter syndrome. All mucolipidosis are autosomal recessive except the Fabry's disease. Okay? It can be a little bit difficult to memorize all the causes of mucopolysaccharidosis. So you will find there are a group of diseases characterized by enzymatic deficiency, but let's try to summarize the most important syndromes and the most important features. So these syndromes are the Hurler syndrome, the Ski syndrome, and the Hurler-Ski syndrome, Hunter syndrome, Sanfilippo syndrome, Morkius syndrome, Mantoulami syndrome, and Sleigh syndrome. So these are the syndromes. As we mentioned, all of them are autosomal recessive, except the Hunter syndrome. It is the one which is X-linked recessive. Regarding the ocular manifestations, all of them will cause corneal opacities, with some diseases cause other associations, like the Hurler syndrome and the Ski syndrome. They are characterized by four main features: corneal clouding, pigmentary retinopathy, optic atrophy, and glaucoma. So the four involvement of Hurler and Ski syndrome. And what about the others? In the Hunter syndrome and the Sanfilippo syndrome, both of them characterized by rare involvement of the cornea. So the Hunter will be like clear cornea or rare corneal clouding. The Sanfilippo's, there will be clinically clear cornea with just when we see the slit lamp, you may find some fine corneal opacities. But this is not the cause of the corneal problems of the patients or the visual loss for the patients. So Hunter syndrome and Sanfilippo syndrome, both of them have common features of having almost normal cornea, and they will also have pigmented retinopathy and optic atrophy. The Morqueus and Mantoux-Lamy, both of them will have corneal clouding and optic atrophy, okay, without pigmented retinopathy or glaucoma. So this will be the main features of each one. Regarding the systemic feature, the most important to know is who will be having mental retardation. Mental retardation occur in Hurler syndrome. They have mental retardation. And the Sanfilippo syndrome, they will have this progressive dementia and behavioral changes. So this will be the most important. So I hope now this table, if you read it, you may find it painful to understand or to remember, but these are the main features that you should concentrate, and these are the areas of asking or the areas of questions in the MCQs exams. The mucolipidosis are not that important. The only important thing about the mucolipidosis is the Fabry's disease. So the Fabry's disease is very important and asked in all details in the exam. What is the etiology of Fabry's disease? It is caused by alpha galactosidase A deficiency. This is the type of enzymes which is deficient in Fabry's disease. We have four ocular features or four main ocular features: cornea, conjunctiva, retina, and lens. In the cornea, they will cause what's called cornea verticillata or vortex keratopathy. These are like horn-shaped corneal opacities. It takes the golden yellow color. This is very characteristic for Fabry's disease. The conjunctiva can show dilated or tortuous conjunctival blood vessels. These are some conjunctival vascular changes which occurs like in around 50% of cases. Retinal vascular tortuosity, again, you see this abnormal retinal vasculature. This retinal vasculature or this retinal vessel tortuosity is also occurs in around 50% of cases of Fabry's disease. And finally, the spoke-like cataract. This is what's called spoke-like cataract, which is also happens in around 50% of cases of Fabry's disease. So don't forget these four ocular features: corneal opacity, conjunctival vascular changes, retinal vessel tortuosity, and the spoke-like cataract. Okay. So this is the mucolipidosis. Are there any metabolic disorders that is not related to the mucopolysaccharidosis or mucolipidosis in the tissues, including the eyes, the kidneys, the lymph nodes, and others? So when these patients present to us as an ophthalmologist, they present due to eye problems. However, they usually present much earlier to the pediatric nephrologist or the pediatrician due to the kidneys, because this can result in kidney failure or renal failure in the early childhood. So how does this patient present to an ophthalmologist? It presents by presence of like needle-like cystine crystals. This is one of the differential diagnosis of crystalline keratopathy. There will be like crystals present in the cornea, all of the cornea, as you can see here, and also present in the conjunctiva, usually seen by the age of 1 year. Those crystals start centrally and progress toward the limbus. This is also important for the MCQs. Start from the center and progress toward the limbus. And those patients, these crystals may result in corneal irritations and erosions, which will cause pain and photophobia. Okay. So The most severe form of the cystinosis is the infantile, associated with death from renal failure in early childhood. That's why if you saw this patient, if he presented to you, this patient should be referred to the pediatrician. This disease also associated with other syndrome and the manifestations like hypothyroidism and pancreatic endocrinal insufficiency, myopathy, and neurological deficit. Treatment is directed toward the clinical presentation and the clinical manifestations, like if they have corneal erosions, this can be treated by lubrication and therapeutic contact lens. And for the original pathology, like the deposition of cystine crystals in the cornea, this can be treated by topical cysteamine. And this was asked before in the MCQ exams in the clinical ICO, asking whether those patients should be treated by topical or systemic cysteine or cysteamine for the corneal lesion. Systemic cysteamine can be used for the organic or systemic lesions. This is a chelating agent that binds to the cysteine, so it will remove the cysteine from tissues. But for the cornea, if you give systemic cysteamine, it will not bind to the corneal cysteine. Why? Because the cornea is avascular. This drug or this cysteamine will not have access toward the cornea. So the treatment is by topical cysteamine, not by the intravenous or not by systemic. The problem is the frequent application that those patients need to have more than 20 or 30 times of application during the whole day, because this cysteamine is accumulating, or this cysteine is accumulating very rapidly. So eventually, if this patient didn't improve on the topical cysteamine, then the definitive management will be penetrating keratoplasty. However, unfortunately, there is recurrence of the crystalline deposits also on the penetrating keratoplasty or on the corneal graft. Okay, so again, we are now speaking about the differential diagnosis of corneal opacity at birth. So we said STUM, S-T-U-M. So what we have next is the P. What is the P? Is the Peters anomaly. Peters anomaly is a rare, congenital, unilateral, or commonly bilateral malformation. So most of cases, those patients have bilateral, but you can see that it is asymmetrical. So what will be the features of Peters anomaly? Peters anomaly is one of the anterior segment dysgenesis. So it is characterized by defect. There be present a central corneal stroma due to a defect present in the posterior stroma. Like in the posterior stroma, the descendants didn't form, the endothelium didn't form, so this may lead to adherence of the iris and lens toward the posterior stroma. And the characteristic feature for the Peters anomaly is the presence of a clear peripheral cornea. So you can see that the cornea in the periphery looks clear, the cornea here in the periphery looks clear. This is one of the most important signs to diagnose the Peters anomaly. And of course, if we are in doubt of Peters anomalies, we order a UBM or ultrasonic biomicroscopy that can delineate the layers of the cornea and can know if there is defect in the posterior layers, which is the sign of Peters anomaly. Okay. So what will be the next? It is the edema. So what is cause of the edema of the cornea at birth? It will be mostly due to congenital hereditary endothelial dystrophy or congenital hereditary stromal dystrophy. A congenital hereditary endothelial dystrophy is a type of corneal dystrophies that is present at birth due to involvement of the corneal endothelium. So we have two types of congenital hereditary endothelial dystrophy. There is CHED type 1 and the CHED type 2. For CHED type 1, it is autosomal dominant, while in CHED type 2, it is autosomal recessive. In CHED type 1, it is a slowly progressive opacity which develops in the first decade. So it starts like in year number 1 and progress through the entire 10 years of life. So actually, that child has like a period of normal vision before the conditions occur. So there is no nystagmus, and those patients don't have deafness as well. So no nystagmus, no deafness. On the other hand, that second type of congenital hereditary endothelial dystrophy is autosomal recessive and present with non-progressive opacity at birth. So the child is born with a non-progressive opacity, dense opacity that is present at birth. That's why this child didn't have an opportunity for any period of his life or any visual clarity, since that he is born with a corneal opacity. So they will present with nystagmus, and they will also can be associated with sensory neural deafness. The characteristic feature is the presence of what's called the ground glass diffuse opacification of the cornea, and due to endothelial decompensation, they may show corneal edema. Another cause of corneal opacity at birth is the congenital hereditary stromal dystrophy. So it will be like the same in the endothelium, but at the level of the cornea. It is autosomal dominant, present at birth or shortly after birth, will show flaky, feathery, white stromal opacities with clear periphery. So you can see that the opacities here are present mainly in the center with the clear periphery. And since that those patients have normal endothelium, so they will have no corneal edema. This is what will differentiate between the CHED and the congenital hereditary stromal dystrophy. Since they have corneal opacification, so they will have sensory deprivation. They may result in strabismus, nystagmus, and amblyopia. Okay. So this will be another differential for corneal opacity at birth. Finally, the last differential will be the dermoid. A dermoid is a choriostoma. What is a choriostoma? It is normal tissue in abnormal location. We will discuss that in more details in the pathology lecture. So limbal dermoid is a mass. Usually it is a purely white, elevated, and it is cystic in consistency and present usually at the limbus, as you can see here. However, it can be present at the inferior temporal region. So this will be the other most common location. So mostly it is present at the limbus and the infratemporal region of the cornea. It can be classified into different grades. So the grade 1 is the most common, which is in this case, it will be present at the limbus or infratemporal region, present as a mass, usually around 5 millimeter in diameter or less. Usually it is limbal or epibulbar, and it can sometimes be associated with golden heart syndrome that we talked about the last time. The grade 2 is the most large, and the most large is present, can be central like that or more large, and those patients can be the largest is the second type. So this will be how does it look like. The third one, or the most severe case, is the third or grade 3, and it is the most severe, and luckily it is the most rare. So in this case, the entire anterior segment is involved. So actually the choriostoma or the tumor is a benign tumor. So it is or a tumor-like condition. It will be involving the whole anterior segment and replacing the anterior chamber, replacing the cornea, the iris stroma, and can be associated sometimes with a small rudimentary eye behind. It can be associated with microphthalmos or posterior segment anomalies. So this can be confirmed by doing a CT scan or doing UBM to know what is behind this dermoid. So this is usually carry a very poor visual prognosis. So these are the different types of limbal dermoids or dermoids which can cause corneal opacity at birth. I hope that this is clear. And this will be the last differential for stumped or the differential diagnosis of corneal opacification at birth. Is it clear?